After that last video I posted, you guys were so interested in PCOS. So many comments asking about a full YouTube video all about PCOS. Heard you loud and clear. Here it is. I'm Dr. Ali. I'm a board certified OBGYN. So let's cover everything about PCOS. I have notes right in front of me. So if I look down, it's because I'm looking at my notes. But we're going to separate this into what is PCOS, signs and symptoms of PCOS, what causes it, what is insulin resistance, what are androgens, health risks associated with PCOS, and lastly, treatment. So buckle up, everybody. It's going to be a good one. What is PCOS? PCOS stands for polycystic ovarian syndrome. I want you to keep in mind, in medicine, when you hear the word syndrome, it typically refers to a medical condition that can affect multiple organ systems. So it's not just isolated to the ovary in this case. Because it's polycystic ovarian syndrome, it can affect multiple areas of the body. PCOS affects about 46% of reproductive age women. Essentially, PCOS is a dysregulation of hormones of the endocrine system. The endocrine system in our body is responsible for hormones, hormone signaling, all that kind of stuff. So PCOS can lead to irregular periods or what's called amenorrhea. It could also lead to symptoms of increased androgens. A little bit later, I will explain everything about androgens, so stay tuned. I am a visual learner, so I'm actually going to draw this out for you all. I'm going to draw what is normal, and then I'm going to draw what happens in PCOS so you all can kind of understand what normally should be happening and why PCOS is different. Keep in mind that I'm not an artist, so this is not going to be perfect, but I hope it's a good way for you guys to understand my explanation of PCOS. Welcome to my drawing. On this side, I drew out what is going to be normal, and then this is PCOS side. So let's do normal first. Again, I am not an artist, but picture this as a brain, and then this is going to be uterus, 2 fallopian tubes, 2 ovaries, cervix, and then vagina is going to be down here. So your brain is going to make hormones that go down and the ovary responds to. So these 2 hormones go down to the ovary. These are going to be FSH and LH. Follicle stimulating hormone and luteinizing hormone. This also involves the menstrual cycle. So in the first part of the menstrual cycle, or what's called the follicular phase, the brain is going to release FSH. The FSH will reach the ovary, and the ovary says, hey, we have a lot of FSH. Let me start to form follicles. So on the ovary, little follicles are formed, and it could be like 3 or 4 that form. And remember, this happens every month. So as this FSH is being released, your ovary is starting to form these little follicles, also called follicular cysts, and these are normal. We want this to happen. Especially as the levels of FSH get higher, your ovary is also making estrogen at this time. Oh, that's supposed to be an increase arrow. Estrogen starts to get really high. These follicles, one of them will start to outgrow the others. This is what's called the dominant follicle. So one of these other follicles will grow, and eventually it's going to rupture and burst, and that is where the egg is released. This whole process is called ovulation. So then the egg makes its way, it's caught by the fallopian tube, and it makes its way to the uterus. Now, as a response to all of this, your uterus is responding to all of these hormone changes. So let's say this is the inner lining of your uterus. As the estrogen starts to increase, your uterus goes, oh, estrogen's increasing, we better get ready for that egg in case a pregnancy happens. So the tissue or the lining inside of your uterus starts to get thick. It starts to thicken because if that egg is fertilized, when it's implanted, that extra tissue that grew inside of the uterus is going to then support the pregnancy. I'll say the little egg is in here, but no fertilization happened. So no fertilization happens, but all of this excess tissue inside of the uterus now needs a way out. So it comes out of the vagina, and that is a period. This is the menstrual cycle in a nutshell. Obviously, there's a lot of other little things going on and other hormones involved and stuff like that, but for the sake of simplicity in this video, this is just like a very basic explanation of the menstrual cycle. As this is all happening, there's also going to be a feedback loop from the ovaries to the brain. The hormones are all communicating with the brain, with the ovaries. The uterus is responding to the increase in the changes in hormones and all of that stuff. So this all works together, and this is what happens normally every single month. You have an increase in hormones, you have a decrease in hormones, they slowly start to rise again, they go up and down, and they fluctuate, and you want your hormones to be fluctuating. That's normal and that's healthy. Now let's talk about what happens in PCOS. With PCOS, your brain is still making those hormones. You're still making FSH and LH. But the issue being is that on the ovary, instead of your ovary just forming those 3 to 4 follicles every month, there's a ton of tiny little follicles that form on the periphery or the outside of the ovary. When we do an ultrasound to look at your ovaries, I don't know if you can see it here, but all of the follicles kind of line up on the outside. So on ultrasound, it's called the pearl sign because it looks like a pearl necklace on imaging. And that's how we know that there's multiple follicles in the ovary or multiple cysts. Essentially, with PCOS, your brain is still making these hormones and it's sending them down to the ovary, but the ovary is not working properly and it can't get a dominant follicle to grow because there's so many inactive little follicles around the ovary. Your brain's going like, come on, I'm giving you FSH, I need you to ovulate, what's going on? And your ovary just simply can't do it. So no ovulation occurs. So what's going on inside of the uterus during this time? Just because you're not ovulating, it doesn't mean that you're not making estrogen. You're still making estrogen. So your ovary's still making estrogen, it's just not regulated well. So the tissue inside of the uterus is still growing because you still have estrogen around your body. But it's not a result of ovulation because your ovary can't release that egg. Remember, if you're not ovulating, there's no egg to fertilize, so pregnancy can be very difficult if you're not ovulating. Now, I don't want you to think that I mean that if you have PCOS, it means that you're infertile or you can't get pregnant. No, that's not what I'm saying. I'm going to talk about that later. But it can be more difficult to become pregnant with PCOS. Now, because you still have estrogen in your body, your uterus, it can still grow, the lining of the uterus, and it can still get thick. So patients with PCOS still get bleeding. The biggest difference is that there's no pattern to it. There's no monthly period, and they may go 2 months, 3 months, 6 months at a time without having bleeding. And then they get their period. But it really is just an overgrowth of this tissue where it overgrew so much, it's eventually going to come out. That's why patients with PCOS have a really hard time tracking their cycle because there's no pattern to it. And then when they usually get bleeding, it's painful, it's a lot, they might have some blood clots in it. That's because it's been an accumulation of this thickened lining over months at a time. So essentially, there's a dysregulation of the hormones trying to communicate with your ovaries, and there's no good communication back to the brain. So your hormones, again, are dysregulated. Now, I mentioned before that having a fluctuation in hormone is normal and healthy, but this dysregulation is not normal. I hope this little drawing made sense. Again, I'm a visual learner. This is how I learn. If you look back at all my med school notebooks and stuff, you'll see a whole bunch of little drawings because that's how I really got stuff to stick. That's just how my brain works. Now let's talk about how we diagnose PCOS. PCOS is diagnosed by what's called the Rotterdam criteria. There's 3 things in the Rotterdam criteria, and in order for you to be diagnosed with PCOS, you need 2 out of the 3. And if you meet criteria for 2 of those, then you have the diagnosis of PCOS. So number 1 is going to be oligomenorrhea or amenorrhea, also called anovulation. What this means is that you have irregular periods and you do not ovulate regularly. Or simply put, you just have too few periods. Number 2 is going to be finding the presence of polycystic ovaries on ultrasound, like I explained earlier. Number 3 is going to be elevated androgens. Androgens are our sex hormones, and this is what can lead to hirsutism. So specifically with PCOS, we can see an increase of testosterone in these patients. As females, we do make testosterone and it's healthy for us, but the level of testosterone that we make is much lower than a male. So in patients with PCOS, they just make slightly more testosterone and can lead to hirsutism, which is a male pattern hair growth, where we can see these patients that have hair growth on their chin, above their upper lip, thicker hair around the thighs and abdomen, and this typically affects about 7 in 10 patients with PCOS. It could also lead to severe cystic acne. All right, now let's talk about the signs and symptoms of PCOS. Again, you're going to see irregular periods or no periods, infrequent periods. You guys get the gist of it now. Like I mentioned before, excessive hair growth, severe acne, obesity, and insulin resistance is associated with PCOS, which we're going to talk about in a minute. You can also see more oily skin, and then of course the presence of cysts or small little cysts on the ovary. Oh, and another symptom of PCOS is going to be patches of thickened, velvety, dark skin that can form, and this is what's called acanthosis nigricans, typically seen in the back of the neck, but can also be seen in the axilla and then also in the thighs or like inner thighs. And this is associated with insulin resistance. So what is insulin resistance? It's a condition in which the cells of the bodies do not respond well to insulin, which can then lead to high levels of glucose in the body. So in a nutshell, insulin's job is to store glucose or sugar back to the cells. So very easy example. Say you're eating a meal, you have dessert, you have breakfast, whatever it may be, you eat it. Then as you're digesting, that sugar goes out into your bloodstream. Your brain's like, hello, your pancreas is like, hello, we have a bunch of sugar. So your body releases insulin, and insulin grabs all the sugar molecules and stores them away. People with insulin resistance, the insulin is released, but your body is not responding to it. So then insulin's out there, but there's no grabbing of the sugars. So when your body's like, what the heck? We just released insulin, but the sugar's still in our body. Let's release more. So your body starts making more insulin, but your sugar is still not being trapped in the cells like it needs to be. Now, some of the sugars are going to be stored away. It doesn't mean that, none of the insulin works, but your body has a poor response to the insulin. And essentially, in a nutshell, this is type 2 diabetes. You have insulin resistance, it's not working well, so then you have a high blood sugar. This insulin resistance is actually associated with acanthosis nigricans, or that velvety darkened patch of skin that we can see typically behind the neck. Now let's talk about androgens. As I mentioned before, I was talking about in the diagram, your ovary is still making androgens, or your sex steroid hormones like estrogen and testosterone and progesterone, but everything is dysregulated. So in conditions like PCOS, you're going to have higher than normal levels of androgens. This is essentially what's preventing ovulation, or that release of the egg from the ovary. Because essentially your body and your ovary realizes like, hey, we have a whole bunch of estrogen running around, so we should be able to ovulate. We don't need to make any more. There's a bunch of estrogen here. So that contributes in part to the dysregulation and the miscommunication of hormones with PCOS. Again, these androgens are specifically in PCOS going to make more testosterone. That's going to lead to that excessive hair growth, hirsutism, acne, all that kind of stuff. Now let's talk about the risk factors, or the health risks associated with PCOS. Remember, at the beginning of the video, I said that this is a syndrome, so it's going to affect a lot of different parts of the body. As I mentioned before, insulin resistance is associated with type 2 diabetes, so that's a health risk. If you have PCOS, you are at an increased risk of developing type 2 diabetes, which could then lead to cardiovascular disease. Also lead to metabolic syndrome, which is tied in with type 2 diabetes and heart disease. And it can also lead to what's called endometrial hyperplasia. Let me bring my diagram back for a second. Like I said before, in PCOS, we see a dysregulated growth of the tissue inside of the uterus. This is what's called the endometrium, or that inner lining of the uterus. It's not growing in a cyclical normal pattern like this side, it's dysregulated. And anytime you have dysregulated growth in the body, it can actually lead to cancer. These cells inside of the uterus are not controlled. They're just growing, 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 growing. And eventually that dysregulated growth, it can turn into a cancer. Now, I'm not saying like in 5 months you're going to develop cancer. It usually takes years and years, but this is why it's so important to treat PCOS, because you want to prevent endometrial hyperplasia or endometrial cancer, also called uterine cancer. This is why having a period every single month is actually very, very healthy, and we want patients to have regular monthly cycles. Another interesting thing with PCOS that a lot of people forget about, as I mentioned before, it is associated with obesity or being heavier set. Our fat cells, even in people who may be thinner, our fat cells make estrogen. Estrogen can be made in the ovary, but it can also be made in fat cells. So with PCOS, you already have an increased and dysregulation of estrogen coming from the ovary, but now on top of that, you have more estrogen being made in extra fat cells. So now your body has all of this excess estrogen running around, and your uterus responds to that excess estrogen. Whether it's coming from the ovaries or coming from fat cells, it's going to respond. So that tissue is going to continue to grow. And again, we want to prevent that tissue from growing because we don't want cancer. Now let's talk about treatment for PCOS. Please keep in mind and remember that PCOS, the treatment for it is not one size fits all. Everyone's PCOS looks very, very different. And your symptoms may be very, very different. Because PCOS is a syndrome, it's going to affect us all differently. So keep that in mind. What might have worked for your friend for her symptoms may not work for you, and vice versa. I think this is the dangers of social media, because so many people come on social media and they're like, this is what I did and this is what worked for me to control my PCOS, and this is what you need to do too. And that's not how medicine works. All of us are so different. So please show yourself some grace and remind yourself of that. The point of treatment of PCOS is to really sit with you, or at least I like to sit with my patients, and I'm like, what are your goals? Because it's very different if your goal is to become pregnant and have a baby, or your goal is to treat the acne, or your goal is to treat the hair growth or the hirsutism, because all of that is different treatment options. I recommend when you go see your doctor, speak open and honestly and tell them what your treatment goal is. Or maybe you're like, I don't want to have a kid right now, but my partner and I are planning to have kids in 2 years. That way you can come up with a good treatment plan that's going to work for you. Now remember, with PCOS, there is no cure, but there are a lot of treatment options, which is great. With PCOS, one of the mainstays of treatment is going to be lifestyle changes. Lifestyle changes equals diet and exercise. It is so, so important to come up with a realistic diet and exercise plan for you when you're managing PCOS. Studies have shown that if patients with PCOS lose at least 5% of their body weight, it can trigger ovulation, which is insane that oftentimes you may not even need medication. All you need is to lose a little bit of weight and it can trigger ovulation. Now, this may not be the case for everyone. Like I said, not one size fits all for treatment, but how cool is that just by making those modifications, it can actually bring ovulation back. Again, losing some weight can help improve cholesterol. It can decrease your chance of developing type 2 diabetes or heart disease. So I encourage everyone, honestly, regardless of whether or not you have PCOS, we know all of the benefits that come with exercise. Make a realistic routine that works for you. Don't sit down and be like, I'm going to start doing CrossFit like right away and do that. Like, be realistic with what you can do with your lifestyle, with your schedule, with your work, with your kids. Because again, my workout schedule may not work for your life, and that's okay. But as long as you're moving your body and making an effort, that is what counts. Now let's talk about diet, because they've recently done a lot of studies and a lot of research on what is the best diet for someone that has PCOS. And they found that a whole food, plant-based diet is the best diet for someone with PCOS in getting the ovulation to return. Now, I'm Puerto Rican. I'm Latina, so I know that switching to a whole food, plant-based diet is not something that I'm going to do overnight. Again, I'm being realistic. If you've ever visited Puerto Rico, you are Puerto Rican, you know that we eat a lot of meat and we pretty much eat every single part of the pig. So for me to say that I'm going to give up meat from one day to the next is not realistic. So keep that in mind for you. Now, what I can do and what I've started to incorporate is that when you look at breakfast, lunch, and dinner, maybe for lunch, I don't have meat and I eat more whole food, more vegetables. And then for breakfast and dinner, I can have a little bit of meat. See what I'm getting at? You're making conscious efforts and then slowly then okay, then I'm only having meat at dinner, none for breakfast and lunch. And you're slowly taking these steps. Now to explain what whole food means a little bit better, because I struggled with the concept when I first was doing this and studying it in medical school. A whole food diet means if you have an apple or you have applesauce, it's better just to eat the apple, right? When you actually eat an apple, you're actually burning some calories because you have to chew and you have to work for it. Whereas an applesauce can be processed, has excess sugar in it, all that stuff. So look at it that way. Whole food means you're eating the entire food. I hope that makes sense. Now let's talk about actual medication. One of the medication options for PCOS are going to be OCPs, or oral contraceptive pills, or the birth control pills. These are typically used with PCOS because they help regulate the menstrual cycle. They help protect that endometrial lining from turning into endometrial hyperplasia or endometrial cancer. And they can also help with the hirsutism or hair growth and with acne. So you're kind of treating a lot of things. Remember, the OCPs are treating the symptoms associated with PCOS. Also, I forgot to mention, OCPs can help decrease the amount of androgens, or those sex hormones in your body, like testosterone, which is good. And there are also other medications like spironolactone that can help decrease those androgen levels. But it's very important that if you decide to take spironolactone to help decrease the androgens in your body, is that spironolactone is teratogenic, meaning you cannot take spironolactone if you're pregnant. So it's always highly recommended that if you're starting to take spironolactone, that you have a good form of birth control or contraception. Because if you were to get pregnant and you're taking spironolactone, it can cause issues with the developing fetus. Now, what if insulin resistance is a big issue and a big symptom for you? We also have treatment for that in the form of medications. Typically, this is a medication called metformin. But oddly enough, and a good thing, metformin can also treat some PCOS, so it's like a 2-in-1. It'll help with insulin resistance and it'll help with PCOS. Help decrease the level of androgens, but can also help stimulate ovulation in some patients. Not everyone, but in some. Okay, so what if your treatment goal is to become pregnant? What are your options now? Because remember, like I mentioned, if you're not ovulating every month, it would be very hard for you to become pregnant. But I want to take just 2 seconds to say that if you have PCOS and if you have been told by another provider, whether they're a doctor, a nurse practitioner, a nurse, I don't care who it is, but if someone told you that because you have PCOS, you cannot conceive and cannot have babies, please get that out of your mind. It may be more challenging and it may take more work to become pregnant, but just because you have PCOS does not equal infertility. So erase whatever trauma, whatever hurtfulness, whatever that one person that told you that, get that out of your mind. Now, it can be challenging. A lot of the times in treatment with PCOS, we want to focus on ovulation induction, which means we want to get your ovaries to ovulate, to release an egg. And we have 2 medications specifically that we can try, letrozole or Clomid. Recent studies have shown that the use of letrozole should be the first line of therapy in patients with PCOS because patients with PCOS who were given letrozole have a higher live birth rate, meaning the chance of taking letrozole, ovulating, becoming pregnant, and then going home from the hospital with a live baby is higher when you compare it to Clomid. Oftentimes, you can do letrozole for a couple months, see if it works, and if it doesn't, you can stop the letrozole and then switch to Clomid. Seen that been done in the past as well. It's not that you can't take Clomid, is that with the research that we have, letrozole tends to work better. So I recommend always starting with letrozole. But again, talk to your doctor. Now say you take the letrozole, you take the Clomid, you're still not ovulating. What would be the next step? This is going to be a situation where me, as a general OBGYN, I would then send you a referral to a reproductive endocrinologist and infertility doctor. They're also called REIs. They are OBGYNs who then went to fellowship for infertility and reproductive endocrinology. They are the experts in the field. They're going to have more insight and will be able to give you more options. And ultimately, if IVF looks like the best option, they're going to discuss that with you. Okay, so I think that wraps it up with PCOS. We touched on all of the topics that I wanted to talk about, and I hope you all found this very helpful and informative. If you have PCOS, if you have a daughter that you think might have it, or if you just have more questions because you were recently diagnosed, I hope this video encourages you, empowers you, educates you, and motivates you to seek out treatment if this is you and you're in this situation. Remember that you're not alone. This affects 4 to 6% of reproductive age women, so reach out to someone if you're struggling with it. You're not alone, and I'm here for you. All right, you guys, I'm gonna take off. I will see you next Sunday for a new video. I hope you guys have an amazing week. Take care. I love you.